My name is Frank Amott. I'm from the European AIDS Treatment Group, program chair of the combination prevention program of that organizations. And I would like to welcome you to today's community webinar. Today's web meeting is going to discuss and analyze and provide impact on mutual learning on the latest PrEP development, and especially the topic of access to PrEP and equity in access to PrEP. We had a situation before COVID-19, and we are since March of that year impacted by COVID-19. So actually I have to mention that this meeting was originally also already planned before COVID-19, but because COVID-19 had an impact on the accessibility and the equity in access to PrEP, we would like to reflect that. Before we start the beginning, I would like to mention that we are nearly 50 participants from very different organizations and stakeholders. It's an open meeting, so the meeting can be heard by anyone that registered and is now participating. It will be recorded, and based on that recording, a written report will be provided afterwards. I'm just mentioning that it's a very open meeting and a very diverse population, and that a written report might be will be provided because some people might evaluate in what kind of form they are participating or articulating their point of view. Very important, we are nearly really reaching the 50 participants. If you have a question, use the written format. You have a gray box and you can type it in there, and you can send it in, type it there. And Jojo from EATG will read out those questions. And as I've said, we have a very tight program. I will keep the introduction actually very short. PrEP is a very important tool in the field of combination prevention. Combination prevention is by AVEC. I found that definition today Googling around, and I like it, a set of strategically selected interventions that matches the needs of a given country or community. So that means that prevention activities are based on the needs. That's how you decide what is done and with what intensity. Already in 2011, a paper by Kurth and al. Was published saying no single HIV prevention strategy will be sufficient to control the HIV pandemic. Within that framework of combination prevention, PrEP meant a very important change of policy or intervention options. As I've mentioned already before, PrEP in Europe or the WHO region of Europe, or even worldwide, how you want to say it, has a very different accessibility in different countries. Time's too short to summarize that at the moment. This accessibility to PrEP has major problems in equity. That means that the access to PrEP is not fair for all populations and communities. We have unnecessary and unfair barriers that hinder people accessing that very important intervention in HIV prevention. Having said that, what would be a very general description of PrEP accessibility in the WHO Europe region, we have to keep in mind that COVID-19 impacted this accessibility and equity. European AIDS Treatment Group has conducted 2 community assessments this spring, and it has shown that a lot of services and also PrEP has been impacted. In some cases, even for the good, in some cases for the bad. But it is undeniable that COVID-19 has an impact on this accessibility of PrEP services. At the same time, we have new developments in PrEP, new perspectives, the injectable, long-lasting PrEP and other findings. Today, we will hear about these latest developments, many of them presented at AIDS 2020. We will have community voices from different countries. We will hear different community and key population perspectives. And in the end, this meeting should help us to formulate the needs in the recent advocacy agenda regarding PrEP in Europe. I'm very happy that nearly 50 persons are participating on a Friday afternoon in July in this meeting. And I would like to welcome with a very first short presentation Ferenc Barczynski from AIDS Action Europe, and he will give a very short presentation on the COVID-19 impact on services out of the perspective from AIDS service organizations.
Thank you, Frank. Hi, everyone, and welcome from my side as well. My name is Ferenc Barczynski, and I represent AIDS Action Europe, and we'll present very briefly, as Frank said, a short snapshot of what we received from our survey that we launched to our member organizations regarding the impact of COVID-19 pandemic, the measures and the policies that come with it. So as Frank mentioned already, EATG had a survey, a rapid assessment from the community's perspective, and this AIDS Action Europe assessment, being a network of AIDS service organizations, is going to look at the same issue from the point of service delivery. Next slide, please. So the survey ran in June and included both quantitative and qualitative questions. And today I will only show you the bit of the statistics and the preliminary quantitative data. So our questions focus on service delivery interruptions, whether the organizations managed to continue their face-to-face meetings or face-to-face service delivery, or they managed to find other options, adapt their services to, for instance, to go to online platforms or doing home delivery services, etc. We also asked our organizations about the financial impact of COVID-19, as adapting to new conditions comes with special extra investment into protection and hygiene measures. And we also asked them how they see their future as organizations if the COVID-19 policies and conditions continue. And we will repeat this assessment in 6 months to see the fuller picture of where the situation developed and how organizations managed to adapt and how much they are impacted by this COVID-19 pandemic. Next slide, please. So as AIDS Action Europe has been working in 2 languages since the beginning, English and Russian, the survey was also prepared and launched in both languages. And here you can see the numbers of organizations and the countries they represent who filled in the surveys. So we totally got 43 organizations responding from 30 different countries in the WHO Europe region. And when you look at the list of the countries, you can see that we managed to have a good geographical balance and also a variety of organizations working with different key populations and providing different services for them. I'm not going to say more about the type of service delivery because that's going to be in a later report, but whatever also organizations who deliver PrEP to the community included in this survey. And the next slide, which is my final slide, as I promised, it's going to be very short. And this is the main findings of the survey and the quantitative survey. So regarding service interruptions, 58% of organizations have stopped or reduced their face-to-face services. Luckily, over 90% of them managed to move some of their services online, and 70% are planning to move further services to online platforms. Where we saw a big difference in the English and the Russian language answers about the level was about the level of service uptake by community. 26% in the English and 57% in the Russian survey replied that the service uptake has been to the same degree as before the COVID pandemic. Financially, already we know that half of the organizations have been affected, and 75% expect further financial losses in the future. 76% reported extra investments due to the hygiene measures, and 51% said that the services will suffer losses if they need to keep up the current measures, and that's why they have to put money into and take it away from services. There was also a big difference in the projection whether the existence of the organizations are at stake in the 2 surveys. 14% of the English language survey respondents and 47% of the Russian survey respondents said that the existence of the organizations might be at stake if this continues on. As I said, this is only a preliminary data, and we will need to look much more into the division of the organizations, not just by language, but also by subregions and key populations, and then we might have a better understanding of what type of organizations and from which subregions they are affected by the COVID financially. So this data which I presented today is already in the hands of the designers, and we plan to launch this one-pager format early next week. And we are working on the longer report where we are going to look at the qualitative answers, which we will be very lucky to get a lot of replies from our organizations. And that should come up sometime soon in August. So that was from my side, and thank you for the attention, and again to inviting me for this webinar.
Thank you. Giorgio, did we receive some concrete questions during this presentation?
At the moment, I have no questions, but I will keep track, and maybe there might be some question afterwards, also for Ferenc.
So all the audience, there is 47 people out there listening. If you would like ask a question to a presenter, please include it in the written text box on the right side, and Giorgio will read it then out. I've mentioned that the European AIDS Treatment Group conducted 2 rapid assessments, and also from the user perspective, it was reported that PrEP delivery, access, and equity was impacted. There was not a homogeneous trend. In some countries, it changed even to the better, but some countries also reported that certain aspects worsened. Before we get into details, I think it's very important to reflect on the latest PrEP development. and also reflect within that what kind of findings have been presented at last week's AIDS 2020 conference. And I would like to welcome Sindra Feuer from ABAC, and she's giving us a presentation. And a last time, if you have a question, please don't hesitate to write it down, type it, and it will be read out.
Great, thank you. Can everyone hear me? I'm assuming you can. I'm sorry you can't see me. Sorry, not sorry. It's a technological error, sorry. So I'm Sindra from AVAC. We are an HIV prevention advocacy group. We work globally. I'm actually based in New York and in France. And it's always a pleasure to work with EATG and to present to the community. So I'm going to give you a really sort of brief and somewhat in-depth view of what's happening with PrEP specifically and PrEP research and also other research, and a bit of COVID and what we can do as advocates. So next slide, please. I'm going to start off with this global map of PrEP scale-up. As you can see, the globe altogether, so far, we have about 650,000 people on PrEP or who have initiated PrEP in the last 10 or so years. This seems like a high number, well, relative to what it's been. However, when you compare this to the UNAIDS target of 3 million people on PrEP by the end of 2020, we're not even there. We're under 20% to this target. And there's several reasons why, and I think probably most people on this call know that access is a big issue, adherence is a big issue, staying on PrEP once you actually finally can find PrEP is a big barrier. So there's ways that we're trying as advocates and as researchers to come up with best ways to get around these barriers. And obviously there's community work to be done to scale it up and implement it better and faster in our communities, but also there's research into alternative mechanisms, interventions, delivery systems, molecules that can get over this daily oral pill taking. So we're specifically going to look at long-acting interventions and on-demand interventions. Next slide, please. So this is sort of just an overview of what's happening in the research field in these alternatives to oral daily PrEP. So, and I'm going to go over all of these in detail today. But just briefly, we've got vaginal rings, we've got other oral PrEP in addition to the Truvada. That's basically the standard right now. We've got long-acting injectables, which we heard about last week at AIDS 2020, which I'll go into. We've got antibodies in research, prevention vaccines. This really is, we are in the golden age of HIV prevention research. This is really a robust pipeline. So there's a lot of exciting things. This specifically, this table is efficacy trials. So these are all of the interventions that are actually in late stage, large scale trials. There are not infinite number, but there's a real robust number of preclinical and early phase development, again, molecules and delivery systems such as enemas and douches and implants and all different types of ARVs that are being looked at. But today we're going to just focus on the things that are really in late stage clinical trials that could be a possibility in the next few years. Next slide, please. So I'm going to start off, of course, with PrEP, because this is, after all, a PrEP webinar. So I want to first talk about what we see on the screen. I don't know if you could actually see it, but right now we actually do have an oral daily PrEP clinical trial that's about to take off, and this is TAF. I think everyone on the call knows that TAF was recently FDA approved at the end of 2019, but only for MSM and transgender women. And Gilead, the manufacturer, made a huge mistake by leaving out half of the globe's population, the people with vaginas. And so the FDA mandated the company that in order for them to get this approval, they also had to go out and to see what happens in bodies with vaginas. So they are actually poised to start a study in African women, and specifically in South Africa and Uganda. COVID set them back a bit, but this is actually going to happen. And that was with a lot of community input and pushing, because it would just be sort of a big faux pas and egregious to have a drug out there that was only for a very select population. And let's just keep in mind that TAF is the alternative really to Truvada. Truvada has been proven to work in all populations, and it's available as a generic. So TAF has some advantages. It's a smaller pill, and it's got a better outcomes for people who already have pre-existing kidney or bone mineral density issues. So another study, well, not another, but a study that we saw last week, the SEARCH study, which was a cluster study in Kenya and Uganda. It was looking at, they called it a fair. Anyway, so they were looking at basically test and treat, which, on a community level, and universal test and treat brought down incidence, HIV incidence in the community by about 30%. But then when they added PrEP to the intervention, it actually brought down community level HIV incidence by 75%. And this was a big deal, especially because cisgender women were shown to have reduced their risk by a lot. And this has been an area of concern around PrEP and cisgender women. 211 is also an issue of research. As we know, 211 has only been proven to work with Truvada and in MSM. So they're looking at other drugs like bictegravir with FTAF to see if it could simplify the 211 regimen, which is some people find a little bit confusing or complicated or hard to plan for. So there's that. And also interesting, last week at AIDS 2020, there was data released. So because it's only for cisgender men so far, there was data released in San Francisco. Bob Grant did a study where he did a pharmacokinetic study looking at whether hormone levels in trans, whether feminizing or masculizing hormones, when they're taken with Truvada, whether there's a contraindication and whether either of the drug levels, whether it's the hormones or the Truvada, are decreased. And what they found is that there's no decreased levels of hormones or Truvada, so they can be taken together. And in fact, in San Francisco, they started at San Francisco AIDS Foundation, they started to initiate trans people with 211 PrEP regimens. I talked about TAF. Interestingly, islatravir is a monthly pill that's being studied by Merck right now, and that's we could see results as early as next year. So we would have a monthly pill to get over the adherence of a daily pill. And then there's also in research right now, there's the dual pill, and this would be Truvada with hormonal contraception for cisgender women. And it's actually doesn't need to go through the whole phase 1, 2, 3 because they're already proven to work. They're just looking at bioequivalence right now, and this could be ready as soon as the end of the year, not the end of the year, within a year. Next slide, please. Okay, so this is our global tracker that we just released yesterday, and it actually goes through, it shows you in time all of the PrEP through the quarters. We track through the quarters and through each country, and this is just an example. You can go to the PrEP tracker and look on your country and see the uptake of PrEP in your country and a whole bunch of other information. And then I strongly, I'm showing it off here. I strongly encourage you to check it out. It's a fun new tool. Next slide, please. Next, okay, next. Okay, so moving to the vaginal ring, there's the Depivirine vaginal ring. It's a monthly ring that cisgender women insert for prevention. It's been proven to work about, it reduces risk about 40 to 65%. It's been sitting with the European Medicines Agency for over a year, for a long time now. They keep requiring more and more data, and this would be a regulatory recommendation for Africa, not for Europe, but it would be for Africa. And supposedly we're going to get an opinion by the end of this month, but they've been promising this for a long time, so we don't know. And also WHO will be looking to qualify it as well, and this would open the door to implementation for African women. Also in research though, so this vaginal ring is loaded with the ARV Depivirine, but like most things, the next generation is going to have combinations of ARVs to make it perhaps more potent, less drug. They're looking at a ring that can be inserted for 3 months, so the drug would last 3 months. And they're also looking to develop a ring with HIV prevention and hormonal contraception. Next slide, please. Okay, so this is the big news from last week from the AIDS conference. So the cabotegravir long-acting injectable, which is the HPTN 083, it was studied in MSM and trans women, and it showed very definitively that cabotegravir as a PrEP injection every 8 weeks is very, 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 very effective at preventing HIV. And in fact, statistically, they're saying that it's superior to Truvada. Now, that's a very strange thing to say, because Truvada, when taken consistently and correctly, is basically 100% protective. So how do you have something that's superior than 100%? Basically, what that means is that Truvada was the comparator arm to Cabo injections, and they saw a lot less infections in the Cabo arm. So let me just quickly tell you the Cabo, it's a very intricate study. They had a drug, an oral drug lead-in. So they took oral Cabo for 5 weeks just to make sure that it's tolerable to the body. And then they would do eight weeks injections once every 8 weeks. And then after 3 years, they do a year of oral PrEP. And the year of oral PrEP is for what they call the tail, because the cabotegravir can stay in the body for up to 2 years, longer in cisgender women. And as it's in the body dissipating, if you're still at risk for HIV, you should be on some sort of protection. Conversations about the tail are very long and interesting. I wish we had time, we don't. But I guess the bottom line is because of COVID, they haven't looked at the concentrations of drug levels in the 2 arms, so they don't know when the people in the study got their infections. So it's really hard to know, was it the drug, was it the delivery, or is it was it transmitted resistance, or did the resistance develop, did the drug itself develop the resistance? So they're really still looking and to really determine what happened. But the bottom line is that we have a brand new sort of radical way of preventing HIV that gets around the daily oral pill, and it gets around having to get refills, although it brings its own challenges, which is to go to the clinic, it's still a medicalized intervention every 8 weeks. And that's adherence, that in itself might be hard to adhere to for some people, but it's an alternative for people who want this. And then I have to say there's also its sister study, HPTN 084, which is in African women. same drug, same everything, same design, and that they're a little bit behind, and they have a DSMB meeting in November to see how it's going. You know, so HPTN-083 was actually stopped early because it was working so well. So we'll see in November, maybe that might be able to stop early, but if not, it goes for, I think, another year or 2 years. But unlike Gilead and Taft, they're being pushed and pressured to wait before they apply for regulatory licensure, to wait until there's data on cisgender women so that they can, it can all be approved together. And I just want to draw your attention to, we put out a policy brief, or a brief, sorry, on HPN-083 yesterday at AVAC, if you're interested in the details. Next slide, please. And then another really interesting research, it's sort of PrEP-like, but it's infusions of antibodies. So it's the antibody mediated prevention. And it's basically where they take, they engineer the same antibodies that are developed in someone living with HIV, the antibodies that they create. So it's an engineered version of those, and then they infuse them every 8 weeks into someone who's HIV negative to see if these antibodies will prevent HIV. And the infusions are every 8 weeks for 30 to 60 minutes. It's not really a scalable intervention. So if it shows that it works, it's not going to go for licensures, but it will inform the science for sure. And there's 2 studies, like most of the others. It's MSM and trans women in the North and African women in the South, global South and global North. Next slide, please. And last but not least, of course, is HIV vaccines. And as I was saying, we are in a really robust period of HIV research. Unfortunately, a couple months ago, the Uhambo study in South Africa was stopped for futility, meaning that it wasn't showing any signs, any signals that it was going to work. And this was sad because this was actually based on, it was a very similar vaccine to the original RV144, to the Thai trial, which has to date is the only vaccine that we've seen proof of concept. It's the only vaccine that showed any sign that a vaccine was possible. So they tweaked it and they studied it in South Africa, and unfortunately they had to stop it. However, there's 2 really promising phase 3 large-scale studies, again, in gay men and trans women in the North and African women in the South. And these are really exciting. They're called mosaics because the inserts in the vaccine are every clade. So if it works in South Africa, it's going to work in Europe and da-da-da-da. So it'll help to protect everyone. And just to make a note that in Europe, it's Spain, Poland, and Italy where these are happening, and that they've just started this vaccine study has just started. It's Janssen is implementing it, and they really need community support and help. It's the first HIV vaccine to be large-scale vaccine to be implemented in Europe, and so it's a really great thing to lend our support to. And then there's PrEP-Vac, which is looking at a vaccine and PrEP at the same time and to see how they interact. So that's sort of it for the HIV prevention pipeline. I'm going to do a little pivot to COVID. Next slide. So this is, as we all know, COVID has a lot of muscle, a lot of money, a lot of science is being thrown at COVID for various reasons. And if you compare, there's about 10 pharmaceutical companies that are working on vaccines for COVID. There's one that's working on vaccines for HIV. And as we know, they're moving fast. There are there's tens of vaccines in different phases right now. And I just want to say and point out that if you look at the left hand, the type of vaccines, viral vector, protein subunit, RNA, DNA, these are all, this is all technology. These are all platforms of HIV vaccines. So they're really borrowing and learning a lot from from HIV vaccine development and infrastructure and sites. So the HIV world has really informed this world, at least scientifically. Next slide. And this is just an idea of where the studies are. There's tens of thousands of people right now in clinical trials for COVID. The yellow is just the new recent ones, not that important. Next slide, please. So another thing that HIV lends to COVID is our community response, our community expertise, our community knowledge. So specifically, we as advocates have been focusing, it's really important to see, and exactly what this webinar is today, is what is COVID's impact on HIV? So it's really important for us to be monitoring this. And it's also important because there's so much research and it's going so fast and it's very erratic and a little chaotic. It's really important that there's community engagement. So we, with our HIV expertise, need to be engaging with other civil society organizations, policymakers, funders, developers, researchers. We need to be on community advisory boards. And in fact, AVAC, along with some other organizations, have started a global COVID CAB that I'll talk about in a minute. And one of the key advocacy things, as we know, is that we really need to fight for equity once there is a vaccine and treatment, but specifically a vaccine. Next slide, please. Specifically on the equity point, COVID vaccines need to be allocated based on a public health criteria, not on nationalism. And I can say that as a US citizen. We can't let these rogue countries hoard all of the HIV vaccines. Public funds demand transparency for public scrutiny. The vaccines must be provided at the costs that it costs for manufacturing. And there's a lot of risk involved. They're actually manufacturing vaccines now before they get through phase 2. So there's a lot of risk that pharmaceutical companies are taking, but really it's the governments who are backing the pharmaceutical companies to take these risks. Now, if they get backed by the governments, there needs to be clear conditions that they're going to distribute them in a fair way. Next slide, please. So this is just the landscape of some of the players, the public sectors, NIH, European Union, Bill and Melinda Gates, of course, welcome. It's no surprise, it's the usual players from the HIV field, a few more of the industry. And then there's collaborators, there's global collaborators as well on the middle line. And then there's some of the community stakeholders who are involved in trying to get community engagement and good participatory practice from the very beginning of all of these research and trials. And it's moving so fast, and a lot of the researchers are not familiar with community engagement, so it's not necessarily happening to our standards. Next slide, and last slide, I believe. So I would like to invite anyone who's interested to come and join. We just, AVAC and TAG and a bunch of other international organizations have just started this COVID-19 Advocates Advisory Board to work with the researchers and the funders and the policymakers, to work with all of the key stakeholders to make sure that community is at the table from the very beginning in the development of vaccines and treatment and diagnostics. And please, if anyone can come join, if you're interested, please get in touch with me. And thank you for, and then just the one thing I want to say is, the response to HIV was the community, and COVID will only be defeated with a response from the community, and that's us, because we're the ones in the HIV community who have done this before, and we need to lead on this again. So thank you.
Sorry, thank you very much for the presentation. I'm sure there have arrived some questions Georgia?
So some question arrived, but for the previous presentation, so we are working with a kind of delay. But I think then there is a question. First of all, there was a question for
Okay.
Ferenc. Yeah.
Okay. So maybe wait a second. What I suggest is that we now take first the questions for Ferenc. And please, everyone that has just listened to the presentation from Sindra, please, if you have questions, type them also in the chat box now. Okay, we have questions for Ferenc.
So the question was from Harriet, and she was asking that the survey that were presented referred to the organization that delivered PrEP. So the question whether there are feedback from individuals who are on PrEP during the survey, if COVID had an impact for them.
No, because as I said, our survey was focusing on the service delivery organizations. But if I'm not absolutely wrong, I think that the EATG rapid assessment had some replies on PrEP users who were talking about this in their replies. Actually, because Harriet, you're from Germany, I have a very interesting point to share. That was one of the PrEP users who was during the lockdown period was going back to take their next prescription, was asked by the PrEP provider, why would one like to use PrEP during the lockdown? So there was already a change of attitude from the service provider, going back to the old good public health policies when people are being policed and morally judged about their behavior. But in our survey, there is no user experience, but rather the service provider experience.
Yeah, maybe I can add here, the EATG survey had some of the user experience, as Ferenc just said. Of course, there were cases reported that people somehow didn't have access anymore to PrEP, that prescriptions were denied by doctors. On the other side, we had also the feedback that the prescription normally given for a certain period of time were then given for a longer time period. There were models of home delivery established, and beside the delivery of the PrEP medication, maybe the biggest impact was at the standardized blood testing every 3 months, because that was suspended in most countries, to my knowledge, and what we could find from the feedback. Do we have another question?
Yes, there is a second question about access to PrEP, and the question is whether, when we are talking about access to PrEP, are we referring to price and affordability or barriers to implementation? And that's, I think, is referred to what has been monitored by the service.
Yeah.
Shall I answer right now? Okay. Yeah. All of it. Any barrier is a barrier. Any barrier to access needs to be surmounted, and price happens to be a huge one. Whether it's price, whether it's you don't have a car to get, or public transportation to get to the clinic. So it's not, this is a comprehensive, holistic program. It's not just about having the medication. It's just having all of the factors line up so that people can take it and access it and afford it.
Yeah, I also would like to stress or underline that argument. There is accessibility and equity on different level. It's the micro user level that maybe has the problem that the pharmacy providing the medication is not very accessible or whatever. And on a macro level, it's maybe the lack of financiation through the public health system. Yeah,
right.
But
Or
all the different levels that affect accessibility and equity.
And I would say that globally, one of the things that really helps access is generics, is the low cost of the drug, which allows health systems to use any extra funding that would have gone to branded drugs to use it to pay for other things like the programs for the PrEP.
Do we have more questions, comments?
Not at the moment. There were comments when we are talking about TAF PrEP. Of course, we are referring to TAF in combination with FTC. And then there was a question about whether we share the material, the presentation after this webinar. I think we will check with the speakers, but in general, the idea is to share this with the audience.
Of course.
It will, and also there will be a written report. I add this also, that there will be a written summary available afterwards. Okay, so that means if there are at the moment not more questions, I would go on.
There is one more question if we have time, or
yeah, last one.
It's rather long. I will read it. Thanks for the answer by Frank and Ferenc. One more question to Sindre. As Ferenc's examples show, COVID-19 brings the risk of a political and moral rollback, e.g. having promiscuous sex helps spreading C19. What to do as an advocate on that?
About the moralizing of people having sex during the time of COVID. Well, you know, I always like to say I don't like to moralize or judge. I like to say that people are sexually successful. I mean, we just keep providing we provide evidence-based ways to protect people, whether there's COVID or not, or whether that's to protect yourselves from COVID or HIV. Follow the science, get people the tools they need to protect themselves while they have sex.
I would underline that. Maybe as a personal comment, I would like to stress out that the moralizing arguments I didn't, in my country, not hear from outside the HIV community. They came also quite a lot from inside the HIV community. So it was not the outside public moralizing. It was people that I know since many, many years as HIV/AIDS experts. And actually, I must say, I was surprised and shocked to hear. So I think actually, for me, the big question was, or the hint was, that COVID-19 reminded me that there is always a need for ongoing advocacy and ongoing information and education. And we never should assume that the job is done and the job is over. Okay, so there is no more question at the moment, Jojo?
No.
Okay, I think that's perfect handing over to the community and concrete community experiences. We will have 2 presentations and some questions and answers afterwards. And the first presentation will be provided by Gennady Rashubkin.
Thank you, Frank. I will present the situation in Eastern Europe and Central Asia. Thank you for showing the slides. The presentation is based on the two assessments ECOM, the organization which I work for, conducted in the end of last year and in this April. So, and the first picture, this is just two short pictures I want to share with you. The first picture is about PrEP. So after this slide, you will see the map, where in green color you will see the countries where PrEP is available, exist and available. In gray, green, the countries where formally we can see some PrEP services existed, and the yellow color is the color for countries where PrEP is planned to be started this or probably next year. So the full projects we can see in Georgia, which was the first country in the region, started PrEP services for MSM, and now it expands the service for MSM and trans women. It is very successful, very interesting, very dynamic project, and practically all other projects are learning from the Georgian experience now. So next was Ukrainian, one of the biggest, and it is the biggest PrEP service in the region. Currently, there's up to 2,800 people engaged. And another one, also very dynamic and interesting PrEP service organized in Moldova. It's a very small, I would say, country, but with very professional and powerful team in working on PrEP and on HIV. Aligned with these three countries, we can see Armenia and the Russian Federation. Armenia has commercial-based PrEP organized by the National AIDS Center, and in the end of last year, for the last 2 years, they engaged 5 people at PrEP. Probably it cannot be considered as very successful experience, but we have what we have. And then the Russian Federation, very rich, very huge country, where you can find PrEP in the form of absolutely untransparent governmental pilot in Chelyabinsk city, which I've got no any information about still. No pilot program, no pilot targets, etc. But also you can find a couple commercial clinics serving primarily MSM people in Moscow, for instance. So they provide mostly counseling and all other services, including the medicine people buy from their own pocket. And the good news that Estonia just started PrEP for the governmental budget. And this is the only country in the region which we can mention as the country with governmental funding for PrEP, because all other countries already started or planned to start PrEP, use the Global Fund support to pay for these services. So Kyrgyzstan, Kazakhstan, Azerbaijan, and Belarus, these are countries which already included PrEP in their funding request to the Global Fund and plan to start these projects or in the end of this year or next year. Thank you. Next slide, please. Yeah, this is just a description of this map. I said it already, so let's go next. Another assessment and another picture I want to show you for fitting the following discussion, I hope. This is the assessment ECOM conducted in the beginning of this year, in April of this year. We assessed how the COVID-19 quarantine affect the work of LGBT community organizations working in the area of HIV in our region. We've tried to cover as many as possible countries, and finally we've collected 33 response from people representing local organizations in 25 cities from such countries as Armenia, Belarus, Bulgaria, Croatia, Czech Republic, Kazakhstan, Kyrgyzstan, the Russian Federation, North Macedonia, and Ukraine. And out of all respondents, 15% were respondents from organizations, those providing MSM and trans people with support related to PrEP initiation and successful use. Next slide, please. What we have got, there are a lot of other findings we've collected from this research, but here are the main important for this discussion, I guess. First of all, after 1 month of the quarantine measures introduced, 87% of respondents significantly limited or completely stopped offering offline services. This is just dramatically huge number of organizations, and this is how the quarantine impacted the whole HIV service, and I believe the same picture we will see in the area of TB, in the area of hepatitis, and all other medicine and health services. Another figure which I guess is very important, that 30% of organizations, only 1 month of quarantine, reduced employees' salaries or planned to reduce the salaries if the quarantine will continue for the next 1-2 months. It says about really huge fragility, the internal system of organizations, along with the service provision fragility, which we see from the first figure. Then 40% of respondents said that the organizations where they work already developed a plan of actions for the lockdown situation, which is quite good. But on the other hand, 60% of respondents for that time reported purely situational design of their work. So it means they had no any concrete plans of action in the situation of lockdown, which is so pity, and also says about the fragility of all our sphere of work. And the last figure I want you to pay attention to is the 60% of respondents reported that the number of clients after 1 month of the quarantine decreased, their clients decreased more than 50%. So the link between community organizations and community is going to be broke by the COVID-19 epidemic. Next slide, please. The special attention we've paid in our research is online services, the services which could be provided through internet or on the basis of contactless contact. Sorry for this. And 70% of responders cover by online services less than 50% of their clients. This is the explanation why they've started to lose the contact with their clients right after the quarantine began. So what services usually are provided in online mode? First of all, this is all type of counseling when people just talking with each other. This is psychological support, counseling and education on HIV and STI prevention, pre and post HIV test counseling and assistance during self-testing, for instance, and legal support for LGBT people. So I'm really glad that people can talk with each other through internet, and significantly less organizations use contactless mode to deliver some services, some goods, such as the provision of self-tests. Only 30% of respondents reported on this practice, and only 3% of all respondents said that they provide PrEP in a contactless mode. Next slide, please. And this is the picture of online PrEP services in EK. Like the black square of Malevich, you can imagine any picture behind it, but practically this is just a black square and nothing more. By reality, online services, which are very important in many reasons, and those are reflecting the general social trend of moving to online, moving of social life, moving of services, of trade, and any other things, is not reflected yet in health services in the region of Eastern Europe and Central Asia. Just recently, ICOM provided technical assistance to Kazakhstan and Armenia and Kyrgyzstan in the development of funding requests to the Global Fund, and we were not successful in promotion of inclusion of online services development. So the majority of medical professionals, medical officials, health officials in these countries, and leaders of communities do not see the necessity of strong attention to the development of online services in the region, in their countries. Now we try to do the same advocacy under technical assistance providing to Belarus and the Russian Federation. We also want to include the development of online services, firstly to evaluate what services realistically can be developed in the first line, then in the second line, but we'll see will we successful in these two countries, or will lose like we lost Kazakhstan and other countries. So this is it. This is what I would like to present to you at this webinar. Thank you.
Okay, thank you very much, Gennady. And I would say we go directly to the presentation of Michael, and have a second community perspective.
Yes, good afternoon, and thank you for the invitation. Can I see the slides, please? Okay, thank you very much. So I wanted to give you an idea about our PrEP center in Barcelona, in Catalonia. Can I have the next slide, please? And just to talk about the challenges we face in our center, but let me just put a context in the situation. On the 12th of March, one of our physicians was diagnosed with COVID-19, and that meant that everybody who was in close contact, and that was 75% of our team, had to go in quarantine. And then 2 days later, the Spanish government declares the state of alarm, and that meant a strict confinement. So the challenges I want to talk briefly about is the continuity of HIV and STI testing, support for people living with HIV, psychological support service, and our PrEP delivery and continuity of the clinical trials. And in the beginning, there was also be talking about the some eventual protection of antiretroviral treatment for against the COVID-19. So I want to discuss a little bit if this could benefit the PrEP users. Next slide, please. So as for the continuity of HIV and STI testing, it was a strict confinement, means that the clients weren't able to come to our center, and we couldn't do either STI testing as laboratories were dedicated to COVID-19 testing. So every other test was simply stopped. What we did working from home, putting on the website and on the answering machine an email address for urgent cases so people could get in contact, and they would be contacted by a counselor and physician by telephone. And if somebody had an STI and needed drugs, then a prescription was sent by email. As for people living with HIV, there are two cases probably: people who were recently diagnosed and people who found themselves displaced, not in the same area and not able to go back to their home and without medication. And again, physicians and counselors would contact the persons by telephone. We would make referrals for people living with HIV by email or telephone. With some teams in the hospital, we have a group within WhatsApp, so we can work very quickly. If people were coming from outside of Catalonia, they needed a health card. We issued those electronically within 24 hours, and the Catalan government allowed to send medication by courier services. Can I have the next slide, please? As for psychological support, we think it's very closely related to our PrEP services, as most of them are PrEP users. We have a service that was created after the need we found from chemsex users. We have 2 psychologists working part-time, and they are treating currently 53 users. Most of them are PrEP users, but also clients from the checkpoint. And the issues they treat basically are 60% is chemsex, but there are other issues like depression, about assuming homosexuality or a recent HIV diagnosis, problems in relationships, or anxiety when having sex and still having fear about transmissions. Now, what they encountered in this period of time, especially in CAN users, if you combine a series of factors like a confinement, isolation, a feeling of discomfort, there's also a lack of alternatives for pleasure, interruption for monitoring if people were having problems with substance use, that always this combination of factors resulted in an increase of substance use again. So the psychologist went on to online sessions of 45 minutes, but normally they have slots in the morning or in the afternoon, and they changed that also for more flexible schedules. So it could be like any time during the daytime. And then for emergencies, there was availability 24 hours during 7 days a week. And for emergencies, we have to think about domestic violence, suicide attempts, and people who relapsed in substance consumption. And then there's another aspect for a lot of people who live alone and have no friends. The loneliness is a very serious issue. And to have like one session a week, they found that was getting very short. And so in these cases, they created like shorter sessions of 30 minutes each, and then they would be able to give like 2 sessions a week. Next slide, please. And as for PrEP delivery, PrEP, we found out that in most parts of Spain, the units, HIV units, stopped delivering PrEP. That was a shocking fact to find out. Not even as we have seen with people living with HIV, that medication was sent from the pharmacy of the hospital. They simply stopped visiting and stopped sending medication. We, from the first moment, decided that that PrEP should go on if people wanted to decide to do so. And so during the first week, we made it appointments separate by half an hour each person to deliver PrEP in the PrEP point center, and that was done by the 25% of the team who was not in quarantine, of course. And then during that week, we moved forward very quickly. We bought auto tests, self-tests, home tests, and we sent the medication because we thought, okay, if we can't do STI, that's probably not the most important, but if people want to go on with PrEP, it is important to know if they are HIV positive or not. So we we organized by sending medication by courier, and we included a home test, and then people would do the test at home, make a picture of the results of the HIV test and send that by email or WhatsApp. And then the physician or a nurse made the consultation by telephone. And as I said, there was no STI testing done. What we did put on a hold, because we couldn't do it in another way, were intake meetings. Those are meetings for people who are interested in PrEP. So we give basic information, and so they learn about it, about the different ways of taking PrEP, and what's needed to start PrEP. Those meetings had to stop, and also we had to stop and put on a hold people who should start. After the intake meetings, people will have a baseline screening, and they had to be put on a hold. This was very not according to us, and when we did start again in the PrEP point in mid-May, we have seen at least 3 seroconversions of people who had to start PrEP. Now, this whole crisis of COVID-19 will have some consequences for the procedures in the future, and we would like to adapt. We have to think probably in the future for people who are doing PrEP need less physical visits. Consultation can be done like every 6 months. Medication can be sent home. People can do home testing, home sampling, and communication can be done by app. We are hard working on these issues, and hopefully in the next 6 months we will change these procedures and the protocol. Can I have the next slide, please? Then finally, the issue about does antiretroviral treatment protect against COVID-19? Now, when we were confined at home, we started a survey because we thought, well, we have a large group. We are the biggest center to deliver PrEP in Spain. We have a large group of people who do not take PrEP, so it would be nice to compare both groups and observe the prevalence of COVID-19 among PrEP users and non-PrEP users. So we worked from since the 16th of March, developed a protocol and a survey, and we sent it to the ethical committee, and it was approved on the 27th of March. So that was very quickly, and the survey was sent out on the 1st of April. Now, it was sent out in Spanish, Catalan, and English, and we received almost 1,400 answers, of which 40% were PrEP users and 60% non-PrEP users. We are working now in the results. Unfortunately, we can't see, we aren't able to notice any differences between PrEP users and non-PrEP users, but basically because we haven't been able to do testing. So it was only based on symptoms. Now, if somebody might have didn't have any symptoms and did pass through the COVID infection, we have no way to show that as testing wasn't available. What we did observe is that the duration of the symptoms were shorter, although not statistically significant, but it was shorter than in non-PrEP users. Last slide, please. So, and with this, I want to finish my short presentation, but I want to acknowledge all the members, all the staff, and all the volunteers who makes PrEP points happen. Thank you very much for your attention.
Okay, thank you. Jojo, did we receive questions for the two presenters?
Yes, so we receive a question from Michael. When you're mentioning medication sent by courier, do you mean that the medication are sent, the ARV are sent to people at home? That was one question for how the drugs are delivered.
Yes, for people living with HIV, the medication was sent at home, but that was done directly by the pharmacy of the hospital. In the case of PrEP, we sent it directly from here to the people at home.
And thank you, Michael. We also received a couple of comments about the previous presentations, and mostly reflecting on the experience of Moldova. And the comment is saying that this Moldova is piloting community PrEP from September 2019, and this year they will be introducing the national program and in the national clinical protocol on PrEP. And also that in Moldova is available an online PrEP service between doctor, person, and staff from NGO. So that's a very good news.
Okay. Are there more comments or questions?
Not at the moment, but I will keep.
As I see, there is a question to Michael and me. to define the priorities for advocacy? Is the question from Georgia.
Yeah.
In the chat box.
Yeah, I asked this question. I would like to add that question, what
Okay.
you both, after describing your concrete experience, see at the moment as the priorities in PrEP advocacy reflecting the current COVID-19 situation. Nadi or Maite, you want to start?
Well, yes, I think that I think there was really a lack of information about what to do in this situation. Like a lot of people were in confinement, and then one of the things we saw is that, and I think there were some presentation also in the IS 2020 conference, where you see that a huge number of people decided not to take PrEP anymore because they thought, well, we won't have sex, and so they stop taking PrEP. So there was a lack of information. I think one of the things we were surprised by was the situation and what's the recommendation. I think as a community group, we should give some clear guidelines to people. People will make their own decision, that's clear, but it should be based on information, on evidence, and not deciding because we don't know what to do. And the other thing I would say that's clearly an advocacy. I think it's unacceptable that HIV units, that hospitals decide for people not to provide PrEP. So you decide to people and say, well, it's a confinement, you can't have sex, and therefore you don't need PrEP. That's very moralistic. And I think that's we have to fight against that. We have to fight for that. PrEP is a right, and people have the right to make their own decisions.
Thank you. Gennady, what would you see as the priority in PrEP advocacy?
Three topics I would like to mention. First, and the main one is the advocacy towards the community, first of all, because the demand for PrEP in communities in the Eastern Europe and Central Asia region is quite low, and it is still an issue to get the community activists on the side of PrEP to ensure them that the PrEP is a really simple, cheap, and effective way to protect a huge number of people in the communities from HIV, and to increase the linkage, cooperation between the community and community organizations, because of the process of PrEP, when people continuously talking about their health. So the next two issues are more programmatic, I would say. First is to ensure the availability of PrEP, because governments are not against PrEP. They just don't want to pay for it. They keep silence. They allow the Global Fund to support these projects, but do nothing from on their side to support it. And I want to just underline it again. PrEP is significantly cheaper than ARV treatment. They will pay then after people will contract the infection. And the third one is the development of online services, because both sides, organizations, medical settings, community organizations, are not really experienced in this area of service provision. And the same clients and the community members are not really experienced in using online services. So we have to advocate for some significant wide education on the use of online.
Okay, thank you very much. And I would like to continue in the program with two presentations reflecting the perspective of key populations. And first will speak Max Appenroth.
Yes, can everyone hear me and see me? Does that work? Perfect. Just as a brief introduction to myself, my name is Max Appenroth. I'm based in Berlin, Germany, and I work for GATE, Global Action for Trans Equality. And for GATE, I am coordinating the working group of trans men and HIV, which is a group consistent of female assigned at birth trans people. And I also currently do my PhD at the Institute of Public Health at the Charité Universitätsmedizin in Berlin, researching the access to healthcare for trans people. And next slide, please. So just to give a short introduction to terminologies, just so we're all on the same page. If I talk about trans people, I refer to people who do not identify with their gender assigned at birth. People may identify as trans men, trans women, non-binary, genderqueer. And on the contrary, if I talk about cisgender people, I do talk about people who do identify with their gender assigned at birth. That means if your gender at birth was female and you identify with the social role as a woman, you feel comfortable in your body, you would be referred to as a cisgender person. And this is also very, very important. Like I've heard it here and there. If we talk about research and HIV research, just to talk about men or MSM or women, it needs to be there needs to be a clear distinction. And I will come back also to a few recent studies where I will give an example where some parts of my community are actually missing. Next slide, please. So now the question, why do we actually need to talk about trans issues in HIV research and prevention? And I will just give you a little bit of an overview about what's going on generally for trans people to then dive into what is happening right now during the pandemic and how my community is affected. Like I identify myself as trans, just to have that on a little side note. And it was already in 2014 that WHO has declared trans people as a high-risk population in regard to HIV. And there is, like, the number of research is slowly growing, but it's still, like, we're still missing a lot of numbers. And right now, like, the numbers that I'm referring here to are from the US, which is from the biggest survey that has been done so far with about almost 28,000 participants. And in that survey, it already had shown that trans people are 5 times more likely to be living with HIV compared to the cisgender general population, and specifically Black trans women of color. That was a really startling number because, like, in this survey, every 5th Black trans women in the US was living with HIV, and this is something that those numbers are highly alarming, and this is one of the reasons why we really need to talk about my community. Next slide, please. And in regard to accessing healthcare and healthcare services, also in means of like paying for medication, paying for testing, and so on. Like sometimes in countries or settings where these things are not for free, this is also a problem for my community because trans people are more often affected by low socioeconomic status, and they experience discrimination in education, work, housing, and healthcare in general. If you look at the trends, like the European trans survey, like this showed that 1 in 5 people, 1 in 5 trans people experience discrimination in healthcare settings, and the highest rates were found in Lithuania, Cyprus, France, Germany, and UK. And going back to the US trans survey, it was actually every 3rd person who reported being discriminated against in a healthcare setting. Next slide, please. And what does this does to my community. Transphobia is still very common. It is common like in basically like in every country. And transphobia affects so many parts of our lives. It is like that trans people are more likely to be living with mental health related problems. And this is not because we're trans, this is because of the situation that we're living in. And because of the financial situations and the problems in the job market and so on, trans people are more likely to engage in sex work. That puts us at higher risk for HIV. Trans people are more likely to be users of drugs and alcohol. We experience violence and specifically sexual abuse and rape at much higher rates as cisgender people. And again, like the barriers that we're facing to healthcare services and preventive care are just, yeah, it's a huge problem. And the problem of being understudied. Like this is something that I can't highlight in like enough in whatever setting I'm speaking. Like there needs to be more research about trans people in general, but specifically about trans men. There was a study that looked into what has been happening in between 2012 and 2015, and there were 32 studies that were inclusive of trans women and HIV, but in the same period it was only 5 studies that were inclusive of trans masculine people, and not even speaking about non-binary people. There is up to date, there is not research in people who identify outside of the gender binary. And because we were talking about the HO 84 and HO 83, those studies researched MSM, cisgender men, trans women, and cisgender women. My community of trans masculine people, we were completely left out. We were not researched in these projects. Like they made high waves at AIDS 2020, but there was a significant community missing. My community, many trans men identify as MSM, but we are how is it called? We are most often excluded from MSM research. I don't know why. I don't know if we have not the right body parts or whatever people are thinking, but we are at risk, and this needs to change. And the next slide, please. Next slide, please. Yeah, exactly. Thank you. So the lack, why these issues are persistent is because there's a lack of knowledge about trans people, our lives, and our experiences. There are stereotypical assumptions of like how and with whom we're having sex. And the problem is that we're often subsumed under the LGB umbrella, like the T is being added, but the numbers about my community they're very often not analyzed separately. And this is also this is a problem because gender identity is not sexuality, and the lived experience of my community differ from LGBs, like cisgender LGBs. And something that is also happening very, very often is that trans women do not belong in MSM research. They're women, they're not MSM, but some trans men actually do. And there needs to happen a little shift of thinking. And the lack of my community being included in planning, conducting research actually leads to the point that if you don't know how to ask the right questions, you won't get the right answers. So trans people need to be included from the very first beginning. And speaking specifically about PrEP, in the next slide, please. Next slide, please. Thank you. So the access barriers to PrEP is that we're broadly excluded from trials. No, one slide back. Sorry, I don't know. I think it might be a bit delayed with the slide. So thank you. So the absence about trans MSM and the risk, for example, the vulnerabilities, it's unclear what criteria should be included in research, but this can be solved if community is being included. Then thinking about, I have a general problem with finding healthcare, generally, but how am I going to talk about my sex life with a healthcare provider if I can't even go there with a general health related problem? And then thinking about for PrEP, for example, in Germany, if you want to have PrEP, you need to go back every 3 months to get tested. If you have to put yourself in an environment that is potentially discriminatory, this is unlikely. It's unlikely that I will go back somewhere where I don't feel comfortable. Next slide, please. I'm going to start talking about it for the next, yeah, thank you. So there's just an example about transmasculine people in PrEP. There was a study in the US that found that a quarter of the participants of a study they actually fulfilled the CDC criteria for PrEP eligibility. Either their like number of sexual partners, they engage in sex work, they use drugs and alcohol, either one of those were fulfilled. And of those who were eligible, 82% saw a healthcare provider in the past year prior to the study. Only almost 65% of those had been actually tested for HIV. Only a third of those had been given information about PrEP. Again, a third received a prescription of PrEP, and only 11% in the end were actually taking PrEP of those who were eligible for it. So you see how the cascade is going down and how, like, where the gaps are that we don't even get the information that we need. Next slide, please. And specifically, like, thinking about the service provision and PrEP delivery during a pandemic, the access barriers that are already that already exist, they are just aggravated by the current situation. And because of the lack of affirming and knowledgeable health service providers, many trans people have to travel to different places. Like, I'm lucky that I live in Berlin and my doctor is in Berlin, but I know a lot of people who come from outside Berlin to get healthcare here. If you're in a lockdown, if you're not allowed to leave your house, or if you can't just because of not being able to use public transportation or whatever, you cannot see a doctor. And for example, there are countries in Central America that have days where only men and women can go out, and there were cases of trans people being arrested because being out on the streets on the wrong day. And this is something that, I mean, I think this experience is very unique for my community and a huge problem. Access and hormones or other medications are highly problematic because supply chains in some parts are interrupted. Many trans people get their hormones, HIV medication, PrEP from actually informal sources, like not from doctors or healthcare providers. They get it like from the off-label market. This is affected by the interrupted supply chains, and prices are at higher costs. So many people cannot access the medication that they need right now, which is something that also I think is fairly unique to my community. And generally, medications are often not accessible. Like, there were some discussions by WHO to think about, like, okay, from a 1 month supply, this should go up to like a 3 or 6 month supply that people should have at home for whatever cases that are happening. With the co-payments or whatever some people might need to pay for medication, this is just not possible for trans people. If you don't have the money to stock up on your medication, like even recommendations like these, they don't help us. And for the last slide, please, the next one. And what comes like to this like structural problem is that a lot of trans people currently are locked up in dangerous and harmful living environments, for example, with unaccepting family members. A lot of trans people have lost their jobs. As I said, many trans people are dependent on sex work. This is in many countries not happening right now, which also puts some people maybe at the risk of, you know, like if there's a client demanding and usually like unsafe practice, but if you're desperate or in need for money right now, you may engage in these practices just to get to make a living. And also what is really concerning at the moment are like anti-trans movements and actions that are on the rise. For example, Hungary just made it illegal for trans people to get legal gender recognition. There is a huge debate in the UK at the moment that J.K. Rowling is using her, you know, her fame and platform to promote anti-trans ideology. In the US, laws are being passed that make it legal for healthcare providers to discriminate against trans people, and the list goes on. This is happening on top of the pandemic that is going on for everyone, but this is what we have to deal with. And the stress of the pandemic and currently like the literal fight for survival and the existence just puts us at like much higher levels of mental distress. And I must say that sexual health And access to PrEP might not even be a priority for my community right now, which is something that is, for me personally, really concerning. Yeah, and the last slide, just my contact information in case there are any questions coming up later. And thank you for your time, and thanks for having me on this panel today. Yeah, thank you.
So thank you, Max. And we have the second presentation from Elias.
Yeah, thank you so much, Frank, and for the EATG to invite me to talk about experience of accessing PrEP during pandemic in England. So just for a start, just to introduce myself, at the moment, I'm a program manager at Africa Advocates Foundation, and I also work for Lower London Hospital as a sexual health advisor. So I'll talk about the experience of providing support and also PrEP during pandemic from our project, which is PrEP and Prejudice. This is a campaign program of work based in England, with the main focus of how to go about increasing PrEP awareness within African communities, just like BME communities. And those are the partners on the screen. There's Africa Advocates Foundation, AGRO, AHPN, Embrace, FAO, and House of Rainbow. Next slide, please. So in terms of our experience, provision of PrEP during pandemic, there are two aspects to look at. What happened during pandemic within Africans and BME communities. So one aspect was that the demand dropped as people were social distancing. They didn't need PrEP, and also during lockdown, people didn't find reported to stopping PrEP altogether. And I think there was also a drive within sexual health PrEP clinics as well. We're advising service users, patients, where possible, to avoid unprotected sex, and especially to unknown sexual partners. And that this aspect, sort of made that in the uptake of PrEP within the migrant communities, sort of went down. But having said that, there was also the aspect of those who were on PrEP, and especially were having it on, on the option of a daily uptake, that is taking PrEP every day. I don't know how many the numbers, but in consultation with some clinics, where there was observation that significant number of people who were on PrEP continued having PrEP even when they are not sexually active, because it's like taking PrEP was a routine. It was part of their routine, so they thought that, well, we can as well continue taking that. So I think those are the kind of the two aspects from our experience working with African migrants during COVID-19 in terms of its impact on PrEP. But I think there are also some other aspects which had some bearings on the uptake of PrEP. So there was also, in terms of information in the community, there was uncertainty in terms of because of COVID, where the clinic opens. Most clinic, as you can wear, just similar to what Michael said in Spain. Most clinic had scaled down. Most of I work in a sexual health clinic myself. Most clinic clinician moved from the sexual health clinic, went to to help with COVID wards. So the services in the GUM PrEP clinic, the staff reduced. And also there was also uncertainty within the community to say, because people, the knowledge out was that a lot of COVID were in hospitals, so people felt very uncomfortable to go to hospitals, to thinking that maybe they'll be at risk to COVID if they go to. Is it safe to go to a sexual health clinic when most sexual health clinics are actually allocated in hospitals? So there was those those aspects as well. There had a lot of impact on access to PrEP. I think the big chunk across England, both migrant communities and gay men everywhere, was the PrEP impact trial. In England at the moment, PrEP is not is free through the PrEP impact trial. And most people, I think 90%, 95% of people across England who are taking PrEP are accessing it through the PrEP impact trial. And because most clinics had closed down, more scaled down, staff had gone to support the COVID ward and other support. What was the PrEP impact trial is that they closed down for new. If somebody was new, wanted to access PrEP for the first time, they were not sort of like encouraging people to come on board and access PrEP. So they sort of like closed down to say, we have got no manpower to support this. I think, again, similar to what happened for other countries, especially like what Michael said, there was the PrEP clinic was technically closed. Although this the PrEP impact trial clinics were scaled down or closed down, still they were able to give PrEP on case-by-case basis, where there was a risk to HIV was quite very high, or the necessity for the patient safety. That was also considered. But generally, the numbers is like the drive when you, an example, if you are working the clinic, you have got a sexual health consultation for a patient, and if you feel that this patient might benefit from PrEP, you couldn't recommend it because what we can advise is that, during the pandemic, please try to avoid and protect. You couldn't recommend to say, okay, one of the things because of, based on the information of sexual health history, you might benefit more from PrEP. We couldn't recommend that because you knew that, the referral pathway to access PrEP through the PrEP impact trial, had the scaled down, reduced. And also that meant that most PrEP clinic was more, again, similar to what others have said. There was more around telephone consultation model where people were being, phoned and have some discussion on the phone, and also posting the, the drug by post to the patient. So the model also changed significantly. And I'll talk about on the next slide. I'll talk about the impact of telephone consultation model on migrant communities, especially Africans. Next slide, please. Next slide. This is my last slide. So in terms of the general impact, I think the background is that we know about PrEP. Sandra talked very well in terms of the numbers people accessing PrEP. In the UK, although PrEP is sort of like through the PrEP trials, sort of like free at access, still we have got a significant high numbers of very low uptake of PrEP within BME communities. An example, before we went to lockdown, within the PrEP impact trial, I think roughly about 20,000 or so people were registered as accessing PrEP. I think less than 4% were actually Black Africans who are accessing PrEP. So that impact of stopping PrEP had a lot of impact on us because we had built a bit of momentum in terms of raising awareness, people were being engaged. And now when there was an opportunity to say somebody was more engaged or thinking about going to access PrEP, and then the clinic were closed, I think that had a lot of, I think it's going to have a lot of impact on our long-term services because we are still struggling in terms of to raise awareness about PrEP within BME communities. So this obstacle in terms of somebody maybe, well, let me try to access PrEP, and then we are not able to access PrEP because the clinic was closed. I think that is going to have a lot of impact on our services. I think the other aspect, again, the telephone consultation model of service delivery, I think from our experience, that has got a lot of, most BME communities, especially Africans, are sort of very uncomfortable to discuss issues about sex on the phone. So that's also at the, sort of negative impact. People were not able to come forward to access PrEP. And again, as Ariel said, in terms of the clinic being, the closure of PrEP clinic for people coming in for the first time so that they can access PrEP. Most BME community, migrant community, in terms of to advocate for themselves, to articulate, to talk why they need PrEP, because you have got to go through the eligibility assessment. most of our communities are not, are not so much empowered to advocate. Some of them to advocate, especially things to do with PrEP around sex. So we've from so far, what we don't know the long-term impact, but what we have observed so far from our project is that PrEP awareness within the BME communities, the lockdown is going to have a long-term sort of impact on our community. And we hope that maybe post-COVID-19, maybe if there can be more, again, more awareness, maybe we can catch up with, to raise awareness about PrEP within BME communities, Black Africans. And from ourselves, what are some of the learning lessons we can learn from here? People are talking about the second wave of COVID. Maybe what can we do in the second wave of COVID? I think we can learn, there are a couple of things which we can learn from. I think if we look at the HIV clinics, I think they did very well in the sense that most patients were given their HIV treatment for 4, 5, 6 months. I think that was very good in the sense that that meant that most patients cannot come back to the clinic during that period, which mostly covered the period of the COVID-19, like what is happening now. I think if there will be a second wave of COVID-19, I think there could be some of the learning lesson could be about how we can ensure that people who are on PrEP, maybe they can be optional for having the PrEP drugs can cover 4 or 5 months, so that people can have adequate supply of PrEP or without the individual coming back to the clinic. And also the aspect about, when you're taking PrEP, we're supposed to come back to the clinic after 3 months to do the STI check and also the liver function, etc. I think there's also, we can also learn like what happened in London around most GUM clinic in terms of treatment of chlamydia, gonorrhea, and others were so scaled down, and most people were able to access their chlamydia, gonorrhea test through the self-testing kit. So I think there's a self-testing option, which is South Health London. So there's an opportunity for, if we're looking at this, how we prepare ourselves for the next wave. I think there was a need to scale up in terms of how we can do it better in terms of self-testing. People on PrEP after 3 months, there's no need for individual coming back to the clinic to do all the HIV, syphilis, etc. tests. Maybe there's an opportunity for people to just to do the test at home, order the test, the kit, and the test at home. So there's an opportunity for that, and in that way, you can free up the clinics. And also, I think one of the other learning lessons, maybe which we can take on board, which is that even during COVID, I think we should be able to continue to raise PrEP awareness in communities, especially in communities where PrEP awareness is still strikingly very low. I think because what happened during lockdown, everything was also locked down. Opportunities to raise awareness. There wasn't much activities taking place in terms of raising awareness about PrEP. So I think for us, I think what the other learning lesson could be is that even during lockdown, especially in communities like migrant communities where we know that PrEP awareness is very low, I think there should be continual opportunities of raising PrEP awareness in those communities. And then just also to my last point, just to add before I finish, is that I think COVID-19 had a severe impact on BME communities, I think in the USA and also here in the UK. And that also had a very big bearing when clinicians were advising to say don't have unprotected sex with other sexual partner, and also considering that we're coming from a BME background, it's important that you take extra precaution, because we have seen high incidences of COVID death in mortality in the BME community. That also had a lot of impact into a lot of Africans, not taking PrEP, and also not engaged in unprotected sex with other sexual partners. Thank you so much for your time.
Okay, thank you very much. We are a little bit late, but it was very interesting to listen to all the presentations. Just to remind, we have one last point now, that is the discussion on what are in the context of the current COVID-19 situations, the priorities in PrEP advocacy. And anyone who is participating, we are up to 50 participants. I really would like to ask you to write your answer to that question into the chat box, because we can include all the written feedback in the summary of this web meeting. So what do you think is, in the context of the current COVID-19 situation, the top priority for PrEP advocacy? And I'm handing over to Ferenc Balczynski from AIDS Action Europe again. And I mean, you have listened, as me, to all these very interesting presentations. How would you summarize the current needs of PrEP advocacy at that moment?
Thank you, Frank. How much time do we have for this discussion? Is it 20 minutes or so?
We have 50 minutes. We will close at 50 minutes past 4.
Yes, so let's keep it very focused. Fiona, could I get the share my screen, because I was taking some notes while we were listening to the panelists. Okay, so yeah, so I think that we really heard a lot of rich presentations from all aspects of PrEP, and then also its delivery in this COVID times. And so we have this 10-15 minutes to have some discussion about, as Frank said, some of the key issues that we heard from the presentation, and how would you see the advocacy priorities for PrEP in these times. So I would like to ask each of our speakers to comment on the issues of the focus of the presentation, especially keeping in front of you that this might be a take-home message for European organizations such as EATG, AIDS Action Europe, or even PrEP in Europe initiative that most of us are connected with. What could be their priorities? And also, as Frank said, I would also encourage everyone to put down your writing in the boxes, so we can either Giorgio can ask us if we have the time, or then later on it can be used in the report. So going through the presentations, I heard a lot of talk about availability and accessibility regarding research on different than daily oral PrEP, and also for need for options for more diverse population. There was cis women mentioned, trans people, especially trans men and non-binary people, the methods of taking PrEP. There was some discussion about accessing PrEP, affordability, price, transport costs, also in the time of COVID, and how low threshold and welcoming are these services, and what are the policies that are coming in because of the coronavirus. There was a presentation about Black African communities in the UK, which came with the main message that we need to focus on awareness and the acceptability of PrEP among different key populations. And when it comes to the COVID-19 epidemic, we see that there's financial difficulties that especially hit hard the community-based services. There's loss of contact with the community because of less service uptake, and that also PrEP providers during the attitude during COVID has changed, and going through a more moraling and policing attitude. And what are the service alternatives that we can think of? Home testing was mentioned, online counseling, fewer physical contacts. And that was also a very interesting part of presentation about the lack of information and uncertainty of information about service availability and also coronavirus. So I'm asking the panelists, what would be your key take-home messages in advocacy? Who would like to go first? Shall we go in?
Gennady had to leave, but maybe Michael?
Mm-hmm.
I can't hear him. I can see that, Max, are you still here?
This is Sindra. I'm happy to go first because I also.
Okay, perfect.
Next step advocacy, just in line with my research pipeline talk. Let's say we know that this is a time of urgent crisis, but I think that we will be here for a while. So there's immediate needs, and then there's immediate longer term needs. So really keeping our eye on a pipeline of research for both COVID and prevention. So maybe if we had longer acting PrEP implemented, we wouldn't have, we could avoid having to have clinic visits and testings, as often. Maybe if we had a vaccine, it would cut out all of the programming. So just keep our eyes on the pipeline as we're trying to push with implementation and our programs up and running. There's always the science that can help us break through a lot of the barriers. And please, as well, join the COVID advocacy as well for prevention and treatment.
Thank you, Sindra. Would like to go next?
Yeah, I mean, I see it just like underline what Sindra said. But at the same time, I mean, what I pointed out, the immediate issues, the immediate needs of my community is just like really, they need to be put attention to the literal survival of certain communities that are affected by the pandemic more severe in many regards. And of course, yeah, I mean, like the long-term stuff, like I've said that from the beginning of the pandemic, that like I've been engaged in projects and everyone was just like, oh, we need to focus on COVID-19. And I was like, I'm actually hoping and I'm optimistic that there is a life after this situation, after this pandemic, and we cannot forget about that. Like if you put every money and everything, all the resources right now just in like COVID and to solve this current issue, what's going to happen after? So like this, like, yeah. I'd like to agree with Sindra.
Thank you much. Yeah, that's very much in line with what Sindra was saying. Don't lose target about the longer term targets that we were talking. Michael.
Very much in line what I said before, but I think that it's all about giving facilities, and if there's something happening like what happened with COVID-19, we have to be prepared about this kind of issues. Now, for example, what we see is that control, delivering of medication, then probably also the way of administration in the future, if we are talking about injections or implants. Now we think about it within one center. We might think about it like everything separately, and basically giving power to the people who are doing PrEP, so they can auto-administrate the way of the controls, the way of getting medication, and the way of getting administration of the drugs.
Elias?
Yes, Elias.
Yeah, I think for me, like I said in earlier on, I think for migrant communities, I think across Europe as well, I think the big challenge is still awareness. People we can see from a lot of conferences we attend, etc. There's still a very poor knowledge, about PrEP within migrant communities. And if you look at the pattern as well, like here in the UK, Black Africans is the second largest population affected with HIV in the UK. But the knowledge about, how to prevent themselves from getting infected, by taking PrEP, the knowledge is still very poor. People still don't believe in, we are within these communities, still people don't believe that, PrEP exists. It's just a trial, just investigating things. So we've still got a long way to go. So I think for me, the focus should be about how can we move these communities where the knowledge about PrEP is still very low, so that they can, get more aware about it and also access it.
Okay. Giorgio, do we have some feedback from participants on advocacy priorities?
I can bring a comment from the audience. So there is a comment from Harriet saying that maybe we can use the experience of the corona crisis for lowering the threshold to access to PrEP. So I think she is referring to have an opportunity to push on with the long-acting PrEP being available soon, have implement more digital online options and other strategies that come out with this new situation.
So, Ferenc, would you like to add something?
No, I think just supporting what the previous speakers were saying, that I think we really need to focus on keeping the HIV movement on track and not give in to the COVID craze, which is also a big threat, but really have to focus on looking at the further targets. And there's still a lot of work to do among key populations, raising the awareness, capacity building, and information. So I think it's a good takeaway messages for all our organizations.
Yep.
Okay. Yeah. Thank you very much. I must say, I feel at the moment a little bit overwhelmed with all the interesting information. Maybe we have missed some points, but I think that's always in this kind of discussions. I'm looking forward to the written report summarizing this webinar. The presentations, if the presenters agree, will be made available. I would like to thank all the participants. We have been 50 on a Friday afternoon in July. I think that's a very good outcome too, and shows the interest. I would like to thank all the different presenters reflecting different angles of the topic, perspectives and vulnerabilities. And also it was very informative to hear about the latest developments. I'm saying goodbye and would like to thank all of you that participated in this webinar. Bye.
Bye.
Thank you. Bye.
Thank you. Bye-bye.
Bye-bye.
Thank you. Bye-bye.